our next speaker. Dr. Amir Jazaeri is a practicing gynecologic oncologist and associate professor in the Department of Gynecologic Oncology and Reproductive Medicine at MD Anderson Cancer Center. Dr. Jazaeri graduated from University of Virginia School of Medicine in 1996 and completed a residency at University of Virginia Health System. Dr. Jazaeri is at the forefront of the immunotherapy clinical trials at MD Anderson for the gynecologic cancers. He is engaged in pivotal research and development related to immunotherapy in ovarian and other gynecologic cancers. His talk today is Immunotherapy for Ovarian Cancer, Hope or Hype?
Great. Hi, everyone. It's a pleasure to be here. Really, nothing energizes clinicians and researchers more than meeting with an organization such as Ovarcome, learning about the awesome work they're doing, and just going back to our institutions to try to work even harder to try to advance the field. So today I have the pleasure of talking to you guys about immunotherapy. And just to sort of talk about a few financial disclosures, I have received financial research funding from AstraZeneca, and I'm on the advisory boards listed here. Many of you are of course aware of sort of the huge revolution that immunotherapy has presented in the cancer field. In 2013, it was declared the scientific breakthrough of the year. However, one doesn't need to be familiar with scientific journals to be aware of immunotherapy. This is the article from New Yorker in 2012. So just over the last 5 years, attacking the cancer using immunotherapy has really revolutionized the way we think of cancer treatment in general. But really, this idea, even though it's worked in the last 5 years, has not been new. So I think many people trace back the origins of immunotherapy to Dr. William Coley in the 1890s, who was a surgeon in New York, and he was sort of touched by a young woman, a 22-year-old patient, who had an accident on her hand. Her hand was caught in between seats of a train, and initially it was felt that this was an infection, but later it became obvious that this woman had a bone cancer, probably an osteosarcoma. And despite Dr. Coley's best efforts, this young patient succumbed to her disease, and this sort of really stayed with this physician. He went and searched all the records of the New York hospital to see if there was anybody who survived this cancer. And he actually found a few cases among many hundreds. He personally went back and he traced back those patients, verified that they were in fact alive, and in all those cases he noticed that there was a coexisting infection at the time of the diagnosis of this type of cancer. And you have to keep in mind this was back in the days before there were antibiotics. So if you got an infection, your body had to kind of take care of it, otherwise you could very well succumb to the infection. And so this created this idea that perhaps the fact that these few individuals survived their cancer, that nobody else had survived, maybe this was related to the infection and the immune system. Now, if we have to fast forward, over 120 years to really truly understand why is it that now it's working, and I'm going to get to that in a second. But that has to do with this individual, who is Dr. Jim Allison, who's the chair of immunology at MD Anderson. And the reason for over 120 years immunotherapy was just a great idea but didn't work had to do with the fact that our immune system, as soon as it gets activated, applies the brakes. It's such a biologically strong system in the body that to prevent collateral damage, to prevent damage of normal tissues as soon as the immune cells are activated against any sort of infection, they also turn themselves off. And so it was the off switch, the brake pedal, that was discovered, or one of the brake pedals that was discovered by Dr. Allison, that has sort of set the stage for where we are now. But before going further, I just want to sort of discuss some of the unique features of immunotherapy, and this is of course in comparison to radiation or chemotherapy, which are the other two main methods of treating disseminated cancers. So in immunotherapy, drugs and treatments affect the immune cells. So we're actually not attacking directly the cancer cells. Unlike many of the other drugs that you heard about this morning, these drugs are not directly attacking cancer cells. They're actually activating the body's immune systems to then indirectly attack the cancer cells. Because of that, there is no cross-resistance to chemotherapy or radiation therapy. So there's the at least theoretical possibility that immunotherapy could prevail when other treatments have not been successful. There are multiple killing mechanisms, and I won't get into details of that, but suffice it to say that we don't have just one type of immune cell, but we have multiple different kinds of immune cells with different functions. Some are short-acting, some are long-acting, some are memory cells. And just like there are certain infections that you might get once, but your body's always protected, there is a potential for memory or long-term protection from immunotherapies. Also, another feature of immunotherapy, as anybody who's been vaccinated knows, is that there's the potential for repeated exposure to get repeated effect. That's not usually seen with radiation or chemotherapy. Radiation, because we use the maximal safe dose, usually at the first administration. And in chemotherapy, usually cancer cells become resistant to the drugs, so subsequent exposures tend to work less well, whereas that's not the case with immunotherapy. And finally, but importantly, there are definitely side effects to immunotherapy, but these are different than chemotherapy side effects. I'll go into that a little bit detailed a little bit later in the talk as well. So when we say immunotherapy, what does that mean? Well, today most of my talk is going to focus on a specific subtype of immunotherapy, which is called immune checkpoint blockade. So immune checkpoints are those brake pedals that I was telling you about that the body applies as a normal protective mechanism. So when we activate against, for example, influenza virus, we don't start attacking the body's normal cells. Dr. Gershenson alluded to one of the pathways, and I'm going to talk about basically two main pathways where there's the most amount of information available. One of these brake pathways, so here the plus is supposed to indicate an immune activating or sort of a gas pedal effect. So there are molecules on the surface of immune cells that interact with their surrounding, including tumor cells, that activate the immune cells. But then there are the inhibitory molecules that act as the brakes. And so drugs that are now available that block the CTLA4 and the PD1, PDL1 brakes are going to be the subject of most of my talk. So these are two important immunoinhibitory pathways, and I'm going to share with you some of the data that's becoming available. Of course, we should mention that melanoma has been kind of the poster child for immunotherapies, really largely because chemotherapy alone has not produced a lot of successes. And this slide is one of a number of publications now that have documented the superiority of immunotherapy over traditional methods such as chemotherapy. So, for example, if you look at the 15-month point here on the x-axis, you can see that the patients that were receiving chemotherapy in this trial, this was one of the first trials to compare the standard of care at that point, which was chemotherapy, to nivolumab, which is one of the anti-PD-1 drugs. And you can see that the group that received nivolumab did a lot better. Some of you may have heard that former President Carter received Keytruda, which is one of these anti-PD-1 drugs, and he had brain metastasis, which is, as many of you are aware, a very difficult area of cancer spread to fight with any therapy. But he had a complete response despite having this brain metastasis. And so, many of you may have heard about that. But what about ovarian cancer? In 2015 was the first publication in using anti-PD-1 drug nivolumab in patients with ovarian cancer. Basically, about 15% of patients, these bar graphs, when they're pointing downward, they show reduction in the size of the tumor. When they're pointing upward, or in this range between the dotted lines, this is stable disease or progression of disease. And you can see that there were several responders, but about 10 or 15% of patients. So because of time, I'm not going to be able to go through the other clinical trials, but suffice it to say that there have been now 2 or 3 other clinical trials reported with similar drugs, not the same drug, but attacking the PD-1, PD-L1 pathway, and about 10% of patients respond. This was a graph that Dr. Gershenson already showed from this publication that shows evidence of disappearance of tumor. Now, I mentioned to you guys that there are 2 of these breaks that we know a lot about, and that's the CTLA4 and PD-1. So in melanoma, they've shown that combining, so inhibiting both breaks on the immune system is superior to just, for example, in this trial, inhibiting just the CTLA4 pathway. So what about in ovarian cancer? Well, the jury's still out. All of the trials that are available in ovarian cancer are trials where just PD-1 or PD-L1 pathways were being inhibited. However, there are studies that are ongoing, and I'm going to share with you the results from one of my patients on one of these trials who's undergoing treatment at MD Anderson. And this is a CAT scan which shows a slice of the body. In this picture, this is the liver on the right side, and here's the spleen on the left side, and in between, the area that's outlined in red, I don't know how well that shows, but that's area of abnormal soft tissue, which correlates with tumor. And you can see that this is a scan from July of 2016, and by the most recent scan, which is January of 2017, that area has shrunk considerably. And so certainly this is not every patient, so I don't need to sort of present this as the typical case, but this is certainly what we like to see more of in patients that are chemo-resistant. So this was a patient with clear cell cancer, with multi-drug resistant disease. But perhaps what's even more interesting is this, that the first scan that I showed you was actually not the patient's baseline scan. When the patient went on the trial in April of 2016, this was the volume of disease. So as many of you can tell by just looking at this, the disease initially grew between April and July, only to then regress. And this is the phenomena of pseudo-progression. So with immunotherapy, another thing that's new or unique about it is sometimes areas of tumor can appear to grow initially. And from experience in melanoma, we know not to believe that first scan, but to always look for confirmation. And so what you can see here is, had we stopped in July and concluded that this treatment was no longer working, this patient would not have had the benefit that she's had up to now. And she's still currently undergoing treatment. But I think I would be misleading everyone if I did not mention something about the toxicities of these drugs. As I mentioned, the toxicities are very different than chemotherapy. So there's no hair loss, there's no numbness and tingling in hands and feet. But the toxicities are that which you might expect if we take the brakes off of our immune system. So what does that mean? That means that our immune cells may attack normal tissues. And that normal tissue can be any tissue in the body. Some of you may be aware of rheumatoid arthritis. That's a joint disease where the immune cells attack the cartilage within the joints, and that can cause painful joints that become inflamed or deformed. Imagine that happening to any part of the body. In the gastrointestinal system, you can get diarrhea. In the lungs, you can get inflammation of the lungs. In the thyroid, you can get too low or too high a thyroid level, and it can really affect tissues, muscles, nerves, the eyes. Fortunately, these side effects are manageable with experience now, but there have been certainly patients in early clinical trials that have actually died of side effects of these treatments. So these are not benign treatments. It sounds like because you're getting your immune system to attack the cancer cells, that's sort of something very benign, but there's definitely increased recognition of the potential side effects, and those risks need to be balanced with the potential side effects. So what's the summary of these are studies reporting on single checkpoint targeting. So just PD-1 or PD-L1. There's about 10 to 15% response rate. Another 20 to 45% of patients have stable disease. So the disease doesn't shrink, but it also doesn't grow. About 15% of patients getting single-agent checkpoint inhibitors have immune-related side effects that require treatment, so they're considered moderate to severe. And so that's kind of where we are with those studies. So where are we going from here? Well, this is a sort of a hypothetical graph that shows the incremental benefit that we've been able to obtain from chemotherapies. So when a chemotherapy works well for advanced ovarian cancer, we can shift the survival curve to the right. So more patients are living longer, but we're not really curing anyone. So you can see that the percent surviving eventually comes down to 0. With immunotherapy, we can't help a lot of patients, but about 30%, 20 to 30%, at least based on melanoma literature, can be long-term survivors. And so the ideal scenario would be to combine something that combines the two curves so we can get a large portion of the population to live a very long time. So with that, I'm going to just talk to you a little bit about some trials that we have at MD Anderson where we're trying to put together that idea. And as part of the Moonshot project, these two trials are targeting patients that have a lot of disease, patients who laparoscopically we've done a score on them based on the initial volume of disease, and their disease is not amenable to primary surgical resection. So these patients would be candidates for neoadjuvant chemotherapy, and we have two trials, one in which the first 3 cycles of chemotherapy are administered, followed by a debulking surgery, and then patients get carboplatin, Taxol, and one of the immunotherapy drugs, pembrolizumab. In the other trial is very similar, except these patients, the first 3 cycles are a combination of chemotherapy plus another PD-1 targeting drug, PD-L1 targeting drug, durvalumab. And then they go on and complete their treatment with additional chemo and immunotherapy. In both of these trials, we are looking at biopsies before treatment and biopsies after either chemo or chemo plus immunotherapy at the time of interval surgery to see what are the biological changes that are happening as a result of these treatments, so we can learn better, we can understand, what are the correlates to people who respond or don't respond, so we don't expose patients who are not going to respond unnecessarily to these treatments. The other trial that's about to open, hopefully within the next couple of months, is targeting patients with recurrent disease. Here, patients go on to get either anti-CTLA4 immunotherapy, followed by at the time of progression with anti-PD-L1 therapy, or they get both therapies in the beginning, and then if they have progression, they go on to get physician's choice. We're interested in seeing if even the physician's choice might work better in somebody who's had exposure to immunotherapy. So, kind of as a last slide, 10 to 15% response rates for PD-1, PD-L1 targeting checkpoint blockers at this point. Based on studies in melanoma, we anticipate that combining immunotherapies might increase the response rates, but the danger is that it could also increase the side effects, and we know that from studies in melanoma. There are numerous other brakes and gas pedals that are being studied in the immune system, and so I think in the next 5 to 10 years we're going to see a whole slew of different combination immunotherapy trials to figure out which ones work best for what types of cancers. And this is just sort of a cartoon to show you these all on the left-hand side. These are all co-stimulatory or gas pedal-like molecules for the immune system, and all of these are brake-like molecules for the immune system. So you can imagine how many potential combinations might be possible. With that, I'm going to stop, and thank you very much for your attention.